That was certainly the best lecture preparation we've ever had at the Fairbanks Lecture Series. My name is Paul Helft. I'm the director of the Fairbanks Center for Medical Ethics. It's my pleasure to welcome you to our lecture series. Please make sure you signed in at the table outside the doors for CE credits. Food and drink are not allowed in the Riley Outpatient Auditorium. Tomorrow, March 8th, we are going to have our first Ethics Fellowship Lunch and Learn. You can learn more about the Ethics Fellowship either by going to our website or by talking to one of us in person. It will run from 11:30 to 1:30 with sessions repeating every 30 minutes. Please drop by. It's in our conference room, the Methodist Noise Pavilion E130. This lecture is being recorded and broadcasted today, and I want to thank our colleagues who are joining us from IU Health Ball Memorial Hospital, West, North, Blackford, Child Life and Creative Art Therapies Department at the Peyton Manning Children's Hospital at St. Vincent, and Reed Health. A reminder to silence all of your electronic devices and then leave the auditorium to return all calls. There are house phones just across the foyer from us. Our speaker today has no relevant financial conflicts of interest. Now, our incredible program coordinator, Annie Mons, has now written at the bottom of my page, "Turn over." Where's Annie? Outside. Thank you, Annie. So I'm going to tell you a little bit about Ann Hannan. Ann is a board-certified music therapist and developed the first music therapy program at Riley Hospital for Children at IU Health beginning in 2000. She's been the director for the Riley Cheer Guild and music therapy program since February 2016. She has over 16 years of pediatric music therapy clinical experience. When she was here doing that on a day-to-day basis, she specialized in neonatal and infant intervention. She's presented locally in the state, regionally, and at national conferences on topics of infant development and bonding, family-centered care practices, professional collaboration, clinical service triage methods, music therapy program development, music therapy advocacy, medical ethics, and professional self-care. She supervises the pediatric music therapy clinicians at Riley Hospital for Children in Indianapolis and serves on various hospital-based committees with a special focus on enhancing the hospital experience for patients, their families, and staff who care for them. She completed our medical ethics fellowship in 2015. Ann currently serves as an at-large member on the state board of the Spina Bifida Association of Indiana and a national advisory board member for the Ukulele Kids Club organization. And I just wanted to personally say that Ann is one of my heroes. And I met Ann a few years ago when she joined our fellowship program, and she is literally one of my heroes in life in general, but certainly around IU Health, and has done inspiring work, and I've learned so much from Ann over the last several years. And I have to tell just a brief personal story. I have a 17-year-old son who's a senior in high school, and he's a musician, and when he heard Ann talk about music therapy, got inspired one summer to raise money for the music therapy program. So he spent his summer busking on the Monon Trail and on Mass Ave in downtown, and raised some money for and just much of that inspired by Ann, who's continued to support him. And so, Ann, I'm among the many people who love you around here. So, all right, I can't wait to hear your lecture.
Oh, thank you so much. Okay, is this working so you all can hear me? Yeah, because they told me I either have to stand still or I have to wear this, and everybody knows I'm not really very good at standing still. So I am so excited to see so many friendly faces here, and I'm nervous about this. And for those of you that know me, know that I don't get nervous before presentations. So when I was talking to my 14-year-old as I was taking him to school this morning, he's like, "Mom, I don't get it. You do this every day. Why are you nervous?" And I said, I think it's because it's really important. And so I'm really glad that you're here. I'll try not to cry, but this is really important to me. So for those of you that, hello, we're going to go really fast. For those of you that were expecting to only achieve these learning objectives, there's actually a little bit more that's going to happen. And what I hope you walk away with is understanding what this process was like for me. Yeah, isn't she cute? That's Gigi. Her music therapist is in the back, Lauren. And so, you know, when you're talking about delivery of compassionate clinical care, how can you not want to utilize ethical principles to deliver compassionate care to someone like this, right? And so you all can think about the eyes and face and spirit of the people that you take care of. And so what I hope you come away with today, is for sure these 4 things that were on the flyer that you got, but also about how meaningful this has been for me and how the world of ethics, which can be scary on the outset for many healthcare clinicians who weren't raised in this mode of thinking, can really see that this can be a beneficial way to support yourself personally and clinically. So I would be very remiss if I didn't point out how I got to where I am, and that is because, as Paul mentioned, I've been here since 2000 at Riley Hospital for Children, at Clarion, at IU Health, at Riley Children's Health, whatever you want to call it. This place has been my home. I even had 2 kids born at IU, and one of them that's been cared for here at Riley for the last 10 years of his life. And then also the Charles Warren Fairbanks Center for Medical Ethics, which this opportunity literally dropped in my lap. And I went to my manager at the time, Sarah Barnett, who's not here because she's doing something really important right now with her whole child life team, but they've all seen my presentation, and you'll learn about that in a few minutes. And, you know, I had to go to my family and I had to go to my clinical staff and say, I want to take a whole day a week away from my clinical work, and I want to go do this. And they all just said yes. Everybody said yes, go apply. Beautiful letter from my NICU manager at the time that said, oh my gosh, you have to go do this. So even though they knew I was being pulled away from patient care, they saw the value of this. And I just am so thankful for all of these people. So this was a journey for me, as we're all on a journey, and we overuse that word, so maybe we'll listen to some journey at the end because that's fun. I don't know. But I want to talk a little bit about what I expected going in and what happened, because this is where everything else that I talk about today is going to fall in. And so I thought that I was going to come in and I'm going to explore medical ethics as it pertains to my clinical work, because I was a clinician and I had been doing that work for 15 years. That I was excited because one of the things that I love about the fellowship is it's a diverse group of individuals from kind of your standard perspective of diversity, but also in the work that we do. And Paul, for those of you that know Dr. Helft, is a classical guitarist, and he's a musician, although he'll tell you he's not a musician, and I still am having a philosophical conversation with him about that because I don't understand what he describes as musician. Anyone that gets up at 5 o'clock in the morning every day to practice and has sculpted nails to beautifully play the classical guitar is a musician. But anyway, I digress. So he just embarrassed the heck out of me every day by telling everybody we met, this is the first music therapist to go through this medical ethics. This was a really exciting thing. And so what I will say is that it has been very exciting, and it has opened up a world for all clinicians that do the type of work that music therapists, art therapists, dance movement therapists, child life specialists do, to an arena of ethics that I think in our minds was always saved for physicians and nurses and people that were doing the biomedical side of work with clinicians. And so this was really exciting. And then I thought, okay, I'm going to complete a project, because I knew I had to complete a project that directly relates to music therapy clinical work. So maybe it's going to focus on increasing access to music therapy services. Maybe it's going to actively support that family decision-making process, because what got me into medical ethics was really challenging end-of-life situations and families making really difficult decisions about the care of their neonates. Maybe, as we've been doing for the last 17 and a half years, address music therapy triage concerns, because from an aspect of justice, we don't have enough to go around. And also quickly learned that although I didn't really know what it was called before I met Lucia and spent a lot of time with her, I wanted to decrease my own personal and my colleagues' moral distress surrounding this really important work that we do. So very quickly, I'm just curious who's here in the room. So how many of you are physicians? Nurses? Clinicians that are not physicians or nurses? Students? And you can be in more than one category. Professors or educators? And is there an other? Did anybody not fall into one of those? Okay, so what are you? A lawyer? Okay, yes, because you're one of those diverse groups that I got to, and then there's one other person that I'm really impressed that he raised his hand in the very back, because he's my husband. So I would like to say thank you to Gabe Hannan, because my family put up with me walking up and down the driveway when it was warm outside reading my ethics text so that I wouldn't fall asleep. And so I felt like that was a safe and contained space that nobody would run over me. But I did have to move, and I felt like I was going to fall off the treadmill, so I didn't do it that way. So what actually ended up happening, and you'll see on the next slide why it happened this way, is my outcomes were very, very different. And that was that I ended up developing a 90-minute interactive training session on medical ethics for pediatric clinical staff to inform their treatment process decision-making, their treatment decision-making process. Okay, that's backwards, but you know, I was doing this last night. And so far, the presentations that I have done is a live plenary to a national conference attendees, and this was for the child life profession, the ACLP. And the reason that I ended up presenting to this group is because, well, first of all, they said, well, you come to a concurrent session at our national conference, and they called the center, and they said, you know you've got a clinician in your department that does this, right? And it just happened to be somebody that was kind of new to our group, and she's like, I'm so sorry, I didn't know. I was like, why would you know? You know, we're still getting to know each other. So anyway, it turned into a 450-person plenary session for 90 minutes on a Saturday morning in Las Vegas. So that was really exciting. Actually, 2 or 3 minutes past the start time, people were still dragging chairs in, and we finally had to cut it off at 5 minutes and get started. So that was exciting, really exciting to be able to bring medical ethics into that many people. As a result, I was invited to do a webinar for that same organization to any attendees that were not able to attend Las Vegas. And then just last week did a mixed WebEx. And what do I mean by that? I mean that there was a room full of people and then like 25 other people calling in individually. So I had people on chat and people in a room together and trying to do an interactive. So it's been really interesting. If you want to talk about doing webinars and having them be fun and interactive, give me a call because I've worked on this for a long time. And that was in Utah. And I did that up in Central Time Zone in Shearerville, had done a presentation in Indiana. So I did a presentation in 3 time zones in about 3 hours, which I've never done that before either. So in this summer of 2018, I will be in Barcelona, Spain, presenting this to music therapy and medicine colleagues at the International Association of Music and Medicine. So I don't know what that's going to look like either yet, because it's one day at a time. So I had a very significant personal transition that occurred in the middle of my ethics fellowship, and I just realized my bio is wrong. It's 2016. I don't know what date it was. It's 2016. I started in 2015, ended in 2016. And here's what happened. I went from this. By the way, this is Maria, delightful young woman, significant developmental delays. She's adopted by 2 wonderful people who care and love for her, and this just happens to be one of the clinical photographs that I had access to this. That looks very different. What happened? I went from being a clinician to being pulled into an administrative position, and I joked with people and said, you know what? I'm never leaving the clinical bedside. Right, Jean? Yeah. Jean Brownlee, she's Methodist NICU. And I've told several people this story. I really thought that I would slip in some sort of like baby pee, vomit, something on the floor on the NICU, break my hip, and they'd carry me out in my 70s or 80s and say, you're done. You are physically incapable of doing this work anymore. So when I was invited to apply for this open position of the Riley Cheer Guild director, I actually went to, we sort of had lost a third of our music therapy team who went to Dallas and is doing awesome things, or Houston, sorry, but anyway, Texas. And so I went to my remaining clinician who's sitting in the back row next to my husband there, and I said, so I've been given this opportunity, and I'm just devastated because I don't want to leave you by yourself. She goes, you got to do it. You got to do it. You've got to do this and take us with you. So I went from not only being an ethics learner, but also a job learner. Really, really new realm for me. From the direct delivery of care to indirect support. So I was supervising my passion, my clinical background, and having to figure out how do I do this and connect that purpose to this while I'm doing this. So went from thinking my focus is going to be on family decision-making support to, okay, again, how can I indirectly impact? And when I had conversations with Lucia about what this project was going to morph into, she said, it's got to be relevant to what you're doing right now. And what I was doing right now was helping my colleagues, my clinicians, people in my profession and related to my profession bring ethics into their day-to-day work and do it in a way that wasn't scary. So I'm going to give you a snapshot now of the presentation that I did. So you're not getting the full presentation, but I want you to kind of understand how this was designed and sort of how this morphed itself into something. So this is the product, but I also want you to have an opportunity to learn about and talk about the process. So it was a plenary, so I like to use a little bit of humor in my presentation. So it was a plenary, and so there's 450 people, and I want them to interact through the whole time, not just ask me questions at the end. So how do you do that? Well, you have them have conversations with their neighbor, but when you get 450 predominantly women in a room, they do not stop talking. So you have to give them very clear guidelines. So ask them to share. So a PIP, plenary interactive partner, you know, it's something that's very attractive, or so this definition is a very attractive person or thing. It's also a seed. And so I told them, this is the seed. You don't have to go anywhere other than understand that we're planting the seed today. Well, then when we have to do it as a webinar, I'm like, okay, I can't hear these people talk. They also might not be in a room with anybody else other than themselves. So now we have a webinar interactive partner, and we all know from Ethics Fellowship that WIP is a work in progress, and we are all works in progress related to ethics. So again, just starting out with kind of getting them aware of why we're here together. And then here's the question, and I want to ask the room this question. I asked everybody to choose 1 through 4. So where are you guys? How many people are ethics? I love it. Oh, yeah, I expected that. Okay, how many people are ethics? I want to learn more. Yeah, and it's okay to put your hand up. I see his hands going like this. Ethics, I will never understand it. Oh, good. Oh, now Paul helped. Okay. Ethics, it scares me. And sometimes it does. Yeah, sometimes it does. Thank you for being honest. Okay, so basically I went through the basic principles of ethics, which I'm not going to do during this. So if you want it, it's in the slides. I can email it to you. But what I really appreciated of my advisement from Lucia is she said, put it in a story. You're talking to clinicians. You've got to make it relevant. So here's the story that I presented. So I just invite each of you, as I move through these next couple of examples, think of your own story. Think of what you do either with patients and families, or what you do to support, because I see there's some leaders in the room, what you do to support the people who are working with patients and families. So this is a pretty typical pediatric example. Child comes into the emergency room. We don't know what's wrong with him, and we got to do some tests. So he has no medical experience, and it's kind of scary. So we know that he's developmentally on target. He's been having conversations with grandma, but he's not talking to staff. He's hiding under the bed covers, right? So as I described those big 4 basics, just talked about that from a pediatric perspective and what does that mean? What does that mean for the family? And so when we talk about autonomy with children and with their surrogates and with their decision makers, it's not only giving consent for procedures and for medical care, but it's also working with the child at whatever developmental level they're at to get assent. We want them to cooperate, because when they cooperate, it is emotionally fulfilling for them, and it actually leads to a suppression of that physical distress. And then obviously autonomy, just respect for persons at every single piece of and step along the way. Non-maleficence, you know, really we want to figure out what might happen to this child and avoid those things, not only from a physical perspective, but from social, emotional, developmental, and family structure perspective. Beneficence, that's why we're all here. We're all here to make sure that our patients receive some sort of good from coming to see us and intentionally improve their well-being. And justice, which I didn't really know that I would be so interested in this, but this actually helps to answer a lot of the questions and feelings of distress that I've had over the years about music therapy services specifically, and that is, how do we distribute our services? For example, we have 2.8 FTEs of music therapists for 300 beds. That means each person has roughly 100 kids they're responsible for every day they're here. That's overwhelming. That makes a lot of us want to just like walk out, back out the door. Similarly, our art therapists, there's 2 of them. So they each have 150 kids they're looking at for potential clients for our services. So we look at acute versus chronic, quantity versus quality, theory and philosophy versus practical application, and flexibility. We have to be able to meet the needs. So again, I just presented to them, okay, we've talked about this. Here's our story again. Now, again, this presentation was for a national conference of like clinicians, and that's child life, but this will apply to each of you. So take a minute and think about what your process is as you deliver care to your patients. What do you do? Most likely it's going to be very similar to this, because this is exactly the same process our art therapists go through, our music therapists go through. I've talked with chaplains over the years and with social workers over the years and with nurses and physicians. We all find out why we need to see a patient. We figure out what's going on with that patient. We make some sort of a plan. We intervene. We evaluate. We figure out what the next steps are. So what I did then is took them through their daily work. So again, we don't want to add work in. We just want to give them a different way to think about things. And so again, put your own name, your own clinical background into all of these things as we talk about this. So we're going to look at this whole process from an ethics perspective. Here's what I think is really important, and this is what I just continue to consider and think about and kind of work on for myself and talk to people about all the time, is why? Why would we take the principles of medical ethics and apply them back to our clinical work in this way? Because I think many of us understand we're talking about ethics and we're getting a consult when somebody's dying. Or we're talking about ethics and we're getting a consult when somebody's refusing care. That's something that just sort of trickles down into our understanding when we're in this medical field and in these really acute care and critical care treatment environments. But here's something that I explored with some of my colleagues, and I was extremely lucky to be able to do these presentations in steps. So I did it to my local team first and was able to get feedback, got feedback from my supervisors and supporters in the ethics, within the ethics fellowship, and then do it nationally, and then do it again, and do it again. So I've been very fortunate to receive a lot of really great feedback. But what I hoped to achieve is, why are we doing this? This is another bucket of language for articulating your rationale for doing things. So if somebody says to you, you got 15 consults today, why'd you go to that one instead of to that one? Well, this kid was dying and they're not going to be here tomorrow. I mean, sometimes it's just as blunt as that. Other times it's a little more nuanced. And at the end of the day, when we leave as clinicians and we feel really terrible and like we didn't do enough during the day, it's because we didn't have a way to evaluate all the good that was done. Because a lot of times the feedback that we get and the stories we tell ourselves is about all the things we didn't get done. So again, a way to articulate why you have made the choices you've made. I tell my clinical team all the time, if you are with a patient, any patient, you have been trained and have all the tools to make the right decision at the right time in that moment. And so I know that you are with the right person at the right time. And if there is someone that feels differently, and that might be that clinician, then we've got to give you language and a way to talk about that so that the feeling of inadequacy goes away. Because the fact of the matter is that everybody in this room that's working with patients every day has done good work all day long. Unless you're a crummy clinician, which I'm assuming that if you're at an ethics presentation over your lunch break, you're awesome clinicians. So this is a way to engage your colleagues in discussion. And some people are probably like, oh, here comes Ann again, we're going to talk about ethics. But sometimes it's fun. Jane Hartsock is one of my colleagues. She's a professor and a lawyer and lots of really cool things. And we had a conversation just last week about where the Harry Potter houses would fall if we assigned one of the 4 major principles to each of the 4 houses. And it was a really cool conversation, which I've shared with Lucia already. So if you want to talk about that, we can do that afterwards. That's a different presentation. So the other thing we do a lot, we spend a lot of energy on, is second-guessing ourselves. Okay, I've got this triage method. I've got this evidence-based practice. I've got all these reasons why what I'm doing is the right thing to do. But then we spend 60 minutes, 90 minutes, 5 days thinking, gosh, I didn't get enough done. That takes energy. That tells you something. When you have that negative self-talk, those of us that know about cognitive behavioral therapy and know about how that self-talk impacts our psyche, first of all, it takes time, takes energy, and it pulls you away from what you really want to do, and that is spending time with your patients. So let's stop. Let's just stop that, because we know we're all experts in ethical decision-making at the bedside, so we don't have to second-guess anymore. It's going to increase our treatment efficiency, because when we look at things from any kind of framework, then we inform our practice, and we don't have to think about it the next time. Oh, this is like what we did last week or last month. You become an advocate for ethical patient care, and you can recognize and identify those things where there might be areas for improvement within your treatment team. You can identify resource growth opportunities. And I hope, and maybe this is a pie in the sky dream, but let's increase our personal job satisfaction, right? Because we all got into healthcare for a really specific reason. It wasn't for the pay. It wasn't because it was a glamorous job. You know, we might slip in baby pee. We might have somebody vomit on us. We might have a colostomy come apart. So it's not glorious work, but there's something really important about it. So let's get back to what's really important. So again, just reminded them what those 4 principles were, and then brought up these really important principles of fidelity and veracity. And these were 2 that Lucia identified with me as being really important in the healthcare setting and really key indicators on moral distress, which she knew was something I was really interested in. And so fidelity about your relationships and the conflict of those relationships between your commitment to your patient, your commitment to your patient's family, that might be in conflict, your commitment to your staff, to your internal department, to your external department, to the greater unit, to the organization. And then veracity is truth-telling. And we've got to tell the truth, but sometimes we have our hands tied behind our back, which is really hard to play the guitar when your hands are tied behind your back, and we're not able to share the full truth. And maybe that's a decision that a surrogate makes or a caregiver makes for a minor. That's a really hard spot to be in. So this was the experiential process for the people who attended the presentation, and that is to go through the whole treatment process as a child life specialist, but insert nurse, physician, art therapist, music therapist, whoever you are. And so I just kind of briefly said, this is just what I think about when I go through these parts of the process. You really think about, it's hard to divide ethics into certain buckets because it's kind of a gestalt opportunity, but at the same time, when you're talking about the referral process, you're respecting that person, and the other competing needs fall into the justice category. Assessment, it's everything. I mean, you got to know as much as you can to provide the best kind of care. So from an ethical standpoint, you're taking your whole toolkit into that. And when you make a plan for a patient, we don't want to commit harm. You know, we want to prevent harm as much as possible, and we want to do some good. Intervention, again, use your whole toolkit. So when you're using your whole toolkit for intervention, you're using your whole toolkit with your ethical decision-making process. Evaluation, did we prevent harm? Did we provide good? If we didn't, we go back to the drawing board again. And then follow-up and discharge is, how do we make sure that the patient, family, surrogate, et cetera, is doing as much for their own health and well-being as possible? That falls right into autonomy. And then the justice of, can I see this patient again? There might be some constraints on my time. There might be constraints on access to services, and they might be going home. So I gave some ground rules during the presentation. There's no wrong answer. There's no wrong answer. Ethics is a framework. It's a way to think about things. And again, when you are providing patient care, that's the right answer. You are providing patient care. You are supporting patients. You're supporting your colleagues. You're supporting the patient's families. You're supporting your organizational goals and structure. There's no wrong answer. But something that's really important to consider, and this is what I hope you walk away with and do some more personal exploration on, is that there are always going to be values that you're focused on that are going to be in conflict. And those are your personal values, professional. Your organization tells you what your values should be, and if you don't want to be a part of those values, you don't work here. No, they don't really say it that way. They're quite kind. But they're always going to compete in a macro and a micro level. And so things that you feel really good about when you're in your office and you're talking about things philosophically change when you get to the bedside and you're in that room with that child and you have lots of competing needs going on. So here is one example of how I started this interactive piece. So I gave them 2 scenarios, and they had to talk about it from an ethics perspective, and then they had to make a choice about what they were going to do. So they're with a patient, 10 years old, chronic condition. This particular specialist, insert whatever you want for medical preparation, but they were doing medical preparation for a surgical intervention, and the patient was alone in her room, no other support, family members, friends, etc. Julie, 5-year-old female patient, referred to services with a call on Vocera. The nurse is getting ready to place an IV. Child has a history of screaming, flailing, crying during placements. Maternal grandmother's at the bedside with the child, but requests to leave, and this is very common, requests to leave the bedside when her granddaughter becomes distressed. If your child, your loved one, is screaming, crying, flailing, you do not want to be in there if you don't have the right kind of support that you need to be that supportive person. So the nurse is requesting procedural support to decrease this child's anxiety. So now we have to talk about this. So they go back to their webinar partner or their partner, whatever. And so which of these aspects of these two competing needs do you consider? And from an ethics perspective, which patient do you choose? So they didn't see this second slide because they had a conversation about it. But just as a reminder, on each slide I had the 4 basic principles and then the additional fidelity and veracity, and just ask them, again, each time through that repetition, which was feedback I got from doing it locally, repeat those terms. I forgot what they were. I had to write them down. So making sure, okay, remember, we're doing this from an ethics perspective. And then after they had time to talk for 4 minutes, I said, okay, so here's my thoughts on this, just to kind of give you a little bit of background about how this process might look if you go through this as a clinician. So Heather, and if you remember, she was the 10-year-old that the child life specialist was physically present with. So from an autonomy perspective, that child life specialist had a prior relationship with that child. So you can look at that from a respect for persons perspective in both directions. I've got a prior relationship with this child. I've made a commitment to this child. I need to finish what I'm doing with this child. You can also look at it from the perspective of perhaps the history of that relationship with that child and her age, being 10, would allow you to say, you keep working on this piece and I'm going to be back at 2 o'clock. So you can look at it from both perspectives. Developmental understanding. She's 10. She's also had chronic engagement from social workers, chaplains, child life specialists. If you're in the pediatric hospital and you've got a chronic condition, you see everybody. So again, she's got this developmental understanding not only because she's 10, but because she is medically literate. And then she has established a treatment plan. And again, you can look at this from both directions. So from a justice perspective, I'm with you right now. You're having surgery, which is a time constraint. I maybe should stay here and finish this medical preparation with you so that you feel confident going into surgery. But also, depending on the nature of the relationship with that individual, it might be that, hey, we know you're having surgery, and you and I have worked on this before every surgery, so here's a task you can complete for the next hour and a half, and I will be back. Julie, acute distress. She's flailing. She could harm herself. She could harm the nurse. That is just very, very basic level non-maleficence. There's some pretty big anticipated harms going on there. And beneficence. We want her to have a successful IV placement so they can run the tests they need to run and she can get the medication she needs. There's a complex family situation. And so we need to respect the child and who she is as part of this family situation. The fact that grandma has verbalized, I don't like being in here when she's upset, is also a clue to us as clinicians that something's going on. And if she's had these experiences in the past, we have a choice point to create a potential for her to not have these experiences in the future, but clearly she's a patient that's going to have more IV starts. She's 5. She lacks a developmental understanding. You can't say to her, we're going to start this IV and it's not going to hurt after it's in. No, you can't do that. So she needs some sort of direct intervention. And then from autonomy perspective, grandma consented to the procedure because she was the guardian that was there to do that, but we clearly don't have assent. So then I made them choose. So for you all, after this discussion, how many would choose to go stay with Heather? Okay, and there's no wrong answers. How many would choose to go to Julie? Okay. And I told them, I said, no matter what we choose, I had to choose something so we can continue along our path. But it was about 75-25 each time I've done this, that we would go with Julie. So again, I did that with each part of the process. And so they had to choose between who are they going to go to. With the assessment, I asked them to look at what information are you going to focus on gathering? Because while we all multitask very well and we can walk in and we can talk to the nurse and intervene with the child and get to grandma all at the same time, I'm trying to create this thought process that's very logical with them, and that is to say you've got to choose. So we went through that and how we were going to choose. I gave them 3 choices about what they were going to plan to do. Are they going to promote an environment of safety for this child? Are they going to work on that added emotional piece that's security? Or are they going to look at future success? We want her to have a good IV start placement now so she can have more. They had to choose. And then, okay, so once they chose, then I said, okay, here's three interventions that I know child life specialists use, so you could insert any 3 interventions that you do as your clinical work, and you got to choose, and why. And we went through, again, the ethical defense for each of those things. They're all good choices. I didn't give them any bad choices. And then when we're doing the evaluation, whose responses pop to the top? Because grandma's going to have responses. Your nursing staff's going to have responses. When you evaluate to make your follow-up, whose responses are going to pop to the top. And again, talked about the ethics of all of that. And then what are you going to do next? What opportunities are you going to get next for the follow-up? So here, I'll just show you. I've got a couple of the slides in, show you the beginning, show you the end. So we want to maximize experience for future success. So that's our goal in the follow-up. And what are we going to utilize? Are we going to use education? Are we going to validate what happened and how well things went or how well they didn't go? Are we going to let this 5-year-old just have some play opportunities and support them therapeutically that way? Or are we going to look at the relationship development between Grandma, Julie, and the staff so that we can take that therapeutic intervention and make sure that there are positive feelings moving forward the next time a nurse in a red coat walks in to do an IV placement, that there's not an anxiety, but, oh, I had a good experience with this nurse. And so, again, had a question for them, talk about it, talk amongst yourselves, and gave some relevant ethical support to reinforce this decision-making process. And so I won't go into the specifics of that because we've only got 20 minutes left. So the next piece that I did is we talk about in healthcare going with our gut. And then we say to ourselves, well, I'm a trained clinician. There's scientific background to what I do. I can't just go with my gut, because going with the gut is messy and it's unsupported. It's not researched. So I want to challenge that to say that when you go with your gut, when you utilize your intuition, it is actually informed by things that are scientific and things that are quantitative, qualitative, and experiential. So our knowledge as clinicians and our knowledge in the length of time that we've been clinicians actually informs our gut, what we call our gut. Our experiences that we have informs our gut, and our personal values inform our gut. So understanding those things, I felt like it was important to point out some of the resources that I personally utilize and that I find organizations frequently encourage clinicians that do this type of work to utilize. And that is, if you've never done a personal values assessment, then you have no idea where your personal values are. But even if you aren't aware of where your personal values are, they come out in your clinical work every single minute of every single day. For those who are looking for something that is, you can call it emotional, you can call it spiritual, you can call it bigger than myself, there's a wellness assessment. And these are actually all IU health tools. They're available through our chaplaincy program. The second one is. The other thing that I wanted to tie it back to, again, what do we know? And what do we easily have access to? And that is, how many of you have read your code of ethics for your profession in the last year? Yay, but that's why you're all here, right? So in the general public of healthcare workers, what do you think the percentage might be for how many people have read through their code of ethics for their profession? Tiny. Okay, I heard 10%. Yeah. So if it's 25%, I would be surprised. What's really interesting is to also read the code of ethics for your colleagues. So for example, if you are butting heads with another professional that's outside your professional, but that you collaborate with on a regular basis, especially if you've worked with them for a long time and never butted heads with them before, what's going on? Something is triggering that disconnect. It may be I'm communicating facts, you're communicating emotions. It could be a lot of things. But one thing to think about is it may have to do with their personal and professional values. And one place you can go before you come right out and ask them, is this about our values? Is go to their code of ethics, because their code of ethics and their standards of clinical practice is what drives their educational background. So if you understand how a social worker views their code of ethics in relationship to treatment, how physicians are asked to view ethics, how nurses are asked to view ethics, it might give you a little kernel of truth that says, oh, I view that a little bit differently, and that's how I was raised. Then it gives you the personal and professional awareness to be able to go and say, hey, is this right? And check it. Say, I think we're butting heads because as a therapist, I look at things this way, and as a physician, I read in your code of ethics that you might be viewing things this way. Is that where our disconnect is? And you can at least have some conversations about that. Of course, what are their institutional resources? Because I was talking to people from a lot of different hospitals. Ethics consultation service, some sort of ethics consultation service is required by a lot of the accrediting organizations. Organizational development, opportunities for peer supervision, and then specifically for them, obviously I wanted to point out what they have from their professional perspective. So what I want to do with the few moments that I have left before I take questions is I just want to even try, and I don't know if I can do it, and I think this is why I was so nervous, to describe the impact that this process has had on me and what I'm realizing that it's continuing to have an impact. And, you know, I kept thinking, okay, the fellowship classes are done, and then I do a presentation, so my project is done. And I think Lucia's comment was, okay, you've done this national presentation for 450 people, you have fulfilled the requirements of the project. Okay, so I'm not done. And not that I wanted to be done, but it was just, I thought to myself, gosh, I'm not done. This is still going on. So there was a distinct increase in my self-awareness, both in my personal life and in my professional life. So personally, I realized that changes in my work environment can change my personal interests. So when I moved from being a clinician to being in an administrative position, all of a sudden I found myself thinking about different things and wondering about different things. And I didn't change. I didn't become like transformatively different because I was doing music therapy services versus being, engaged with the community through advocacy, but something changed in me personally, and the things that I'm just naturally drawn to are different. And my mentor realized that as we went through. She's like, this project that you planned at the beginning is not going to work because you're not doing that anymore. So I wasn't sure how to say this, and hopefully this makes sense because I did this really late last night, but non-mandated research and evaluation within the work environment. So, you know, many people are involved in traditional research. It's gone through the IRB. You're part of an NIH study. But what I realized is we're always doing some kind of research, whether you want to call it transformation because you're part of IU Health, whether you want to call it quality improvement, system evaluation. We're all doing research all the time. If we're still here after, you know, that initial introduction to the healthcare environment, then we want to make things better, and so we're always questioning ourselves. And so if that doesn't hold a personal value, you will not follow through with it. So when I come in and say, gosh, I really want to help the emotional distress of parents when they're making these really hard end-of-life decisions, yeah, that's a great thing. And when I was a clinician, that's what was distressing to me. But when I became an administrator, that was no longer something I could have a direct impact on. So while I could have still done that work, and while it would have been valuable work to someone, it didn't have the kind of impact that what this is having right now. And that is, okay, I have this information. I know that a lot of my clinician colleagues are kind of scared about ethics. I also know they all have to get continuing education credits in it all the time. And how about we give them something that's a little fun and accessible that they can use every day, not just when somebody is either dying or questioning treatment. From a professional perspective, the level of impact in any scholarly work that we do exists in the large picture. These are words from my wonderful friend and colleague and hero, Helen Schumark. She's Australian, and so sometimes words don't make a whole lot of sense, but this is what she said. And so, Lauren, if I get this wrong, you can tell me. But she talked about the macro, the meso, and the micro. So I've definitely heard macro and micro. So meso is just what's in between. And so, so anytime we do things, I think remembering that what we are doing impacts from wherever we are. So if you are working at the bedside, you're micro. You're right there in the thick of things. If you are kind of in a supervisory role or what they used to call middle management, which doesn't seem to make any sense in the healthcare context, then you're in the middle. And so you have a Lord above and you have someone that you're serving below. And so that's going to impact how you do your work. And if you are at an administrative level, you're looking at that big picture. But everybody, no matter where they are in those levels, can impact those levels. So you cannot be working at the macro level and not understand what the people at the micro level are doing. You cannot be working at the micro level and only speak about and understand the micro level, because you need to be able to communicate through all of these levels. So that was really impactful. And then the communication of the, quote, final product must include a description of the process and an explicit connection to the purpose for the recipient of the information. So what does that mean? It means that when I talk to all of you who are actually interested in ethics, this feels very different than when I talk to somebody that I know is scared and shaken in their boots about ethics. And when I talk about the impact of this project and the fact that I was gifted time from my clinical department, gifted time from my brand new position to do the medical ethics fellowship, I have to be able to describe why that's impactful to whomever my audience is. So, principles in action in healthcare. Oh, yeah, just put those across the bottom again, because that's fun that they can float up from the bottom. Okay, so our administrators in healthcare are focused on that macro level planning and communication of that macro level planning. Administrative support staff are working within that structure with micro level administrative tasks. Primary clinicians have macro level expertise. You are all experts in the work that you're doing. But you are having a meso level or mid-level delivery of care. And what that'll make sense here in a minute. So clinical support staff are doing micro level care tasks. Now you could be at any of these levels, and you may be a primary clinician doing micro level care tasks, or you might be supervising someone to do those micro level care tasks. Non-clinical staff, again, they have macro level expertise. These might be your people in nutrition and dietetics. They might be your individuals in clinical engineering, your people in environmental services. And they're doing some meso level intervention. So again, they might not be having a direct touch to the patient, but they have this macro level of expertise, and they're working kind of in that mid-level. Non-clinical support staff are doing the micro level of implementation of the individuals that have that large level of expertise. So what I hope you're seeing, and where my brain was going in this is making this applicable to all of us at all levels, is that, okay, we've also got our patients. They are having a micro level experience. This experience in healthcare is about them, only about them, and should only be about them. All these things that are happening all over the place, big level, middle level, direct level, are impacting this micro level experience, and they should not be aware of the frenzy that's going on up here. They should have this micro level experience that is all about them. Families are having a macro level experience from the perspective of they are watching what's happening to their loved one, whether it's a parent to child, a spouse to partner, whatever that is. They're not experiencing the clinical interventions, but they're experiencing their loved one's experience of the clinical intervention. So they are looking at this macro level experience, and some of them are expecting to understand the macro level experience. And how many of us actually walk in thinking, well, that parent needs to understand why I'm doing this direct care task, because we understand intrinsically, or at least we hope, that our organization has done all this work with all these experts to create the best care possible. But perhaps our families are looking for something a little bit different. And then our community is experiencing everything. So sometimes our community members are friends and family of people that are having a healthcare experience, but they're not in the building. So they're hearing about it. They're hearing about it. They're seeing things on Facebook. They're seeing videos on YouTube. They're just, they're experiencing sort of that once or twice removed experience. They're also seeing commercials from our foundations and our fundraising organizations. They're seeing commercials directly from IU Health about who are we? Best care designed for you. IU School of Medicine. We're creating physicians and that are going to behave in this way. IU School of Nursing. We're raising nurses to behave in this way. So we see all this information, and community members take that in. they bring that macro information into their experiences, because chances are they're either going to be a patient someday in one of our hospitals, or they're going to be a family member, or they're going to still remain a part of our community, and it impacts everything we do. So I do this just as kind of a, hey, think about this. I don't really have anything else to say about that other than when I talk about and try to put out there what this impact has had for me, this is why I'm tired all the time, because these are the kinds of things I'm thinking about. So this is the last slide, and future work is how do we continue to translate medical ethics directly to the bedside. We do a great job of intervening in crisis. We even do a pretty good job having lecture series and intentionally introducing our community here at IU Health and beyond to a wide variety of topics related to ethics. But there's more work to be done. And bringing it to the bedside from the perspective of everybody needs to understand that they have a piece of this and it's not just in crisis, but then also perhaps take it even further and intentionally think about how medical ethics can impact in a proactive way that patient experience, and then that loops all the way back around to having a positive impact on our community. So thank you everyone for coming today. This has just been a wonderful opportunity for me, and now we actually have the right amount of time for questions. 2 slides. I'm supposed to fast forward 2 slides. Oh yeah, my references, but they're very basic. They're just the 3 books that we read. So there we go. So for questions at the end of lecture, text this number. And oh yeah. Oh, sorry. Well, I'm sorry. Yeah, if you're here, ask the question via Annie's microphone. If you're not physically in this room, hi, thank you for coming. And then, yeah, text for the question. Okay, good. I was going to be sad if there were no questions. I'm going to take a drink while you ask your question.
Hey, I just wanted to ask, initially, what were some of your expectations before you attended the ethics fellowship? Just so I was a little bit curious of what you thought of it from the
What I thought of the fellowship? So I read
what did you think about the ethics fellowship before you actually entered in? Like, what was your perspective of that?
So before I applied, or after I was accepted and knew I was going to be doing it?
Before you applied.
Before I applied.
And how has that changed?
Yeah. So I didn't know anything about it. So I guess I had no expectations. And when I read the description of it and the application process, I forwarded it on to my mentor immediately. And she said, oh, yeah, I've been seeing that for years. I've always thought that I would love to do that, and you should definitely do this. And then I talked to the manager on my clinical unit, and I said, it's going to pull me away from direct care. Oh, yeah, you should do it. So I kind of didn't have any expectations other than the fact that what drew me to it was a few really challenging cases where all of these concepts came into play for me from a bedside clinician perspective, about the family's experience, the staff's experience, the patient's experience, and all of those things. And I was like, so I think I just was ready to jump off the ledge of, I need to educate myself about this because I'm having feelings that I don't understand. So, and then how did it change afterwards? Well, I guess when I first walked in, I thought, okay, these are my requirements. I got to read thousands and thousands and thousands of pages of scholarly text, and I've got to attend every Wednesday and have really cool opportunities to meet all these awesome people, and then I got to do a project, and then I'm done. And so the difference is that I'm really glad I'm not done. Yeah.
That was awesome, Anne. It sounds as if, given the reception that you had at your national meeting and then being asked to the international meeting, that there was a hidden hunger for conversation about ethics at the bedside among child life specialists.
Yeah.
And I just wonder where the ellipsis was before, where was it missing, and why has your work resonated so much with your colleagues around the world?
So help me out, clinicians. When did music therapists start to have a formal ethics requirement in our continuing education cycle? It's been less than 10 years. 5, okay. And the same thing happened for child life. Art therapists, what about you guys? Is that always been a requirement? Okay, social work? Always. Okay, so I think that for some of the younger professions that are specifically in pediatric healthcare, it was always something that I think they thought was just happening through their other training, but it was explicitly identified. And then all of a sudden, when it was explicitly identified, they're like, how am I going to do this? And I'm scared about this, I'm nervous about this, or I go and it's dry, or we're going to talk about dying kids. So there's a misperception about what ethics was and how hard it might be or how dry it might be. And so I think when my local team came to the presentation and they're talking and they're writing and they're creating models for themselves and they're walking away with some tools of, and I got some feedback that said, I had a situation that afternoon, and had I not been able to look at it from an ethics perspective, I could not have even answered my colleague when they asked the question about why I was doing what I was doing. So again, it's just expanding their repertoire, and I think they're excited about that. Plus, they're also being told by their credentialing boards, you got to do it. So if you're going to do it, let's have some fun. Yeah. Any other questions, comments, feedback?
All right, well,
I would just like to say how much I appreciate the opportunity to go through the fellowship. So if any of you in here have not been through the fellowship, I'm putting a plug in for the Lunch and Learn tomorrow. Seriously, find out about it or contact somebody that's on the adjunct faculty page. And it doesn't matter who you are or what you're doing, you're what we want. And so please consider that. And I will be here if you have questions or want to say something that you didn't want to say in public. And thanks again for everyone. And thanks to my husband for coming, hear me present, and for supporting me. So.